Pseudo-obstruction syndromes. Post-op ileus is impaired GI motility that happens in all patients having a GI surgery. Prolonged post-op ileus is delayed recovery of intestinal function in the absence of a mechanical obstruction. So the patient does not pass any flatus, he cannot tolerate any food. Normal or obligatory post-op ileus is less than 4 days from the surgery. Risk factors: the type of surgery. Colorectal surgery, genitourinary surgery is more prone. Hip and knee surgery is more prone. Spine surgery and cardiothoracic surgery as well. Infections: intra-abdominal sepsis and sepsis in general. Local inflammation like peritonitis or pancreatitis. Retroperitoneal hemorrhage. Metabolic problems like hypocalcemia, hypermagnesemia, low potassium, low sodium. Drugs that we use like opioids, anticholinergics, and anesthetic agents. And pain in general also causes a post-op ileus. The mechanism is a sympathetic overdrive and mu receptor agonist activity. Propofol has minimum effect on GI motility compared to other anesthetic agents. A CT can distinguish between a post-op small bowel obstruction and a post-op ileus. Prevention. Carbohydrate loading was supposed to be good before the surgery, but now they say that you can just give clear liquids 4 hours prior to the surgery. Early post-op feeding is supposed to be good, and therefore we do not do any more NG decompression post-op. We start the patient on feeds as early as possible. Laparoscopic surgeries are preferred because they decrease the risk of post-op ileus. We use opioid-sparing analgesics. We give epidural anesthesia to reduce pain, and we use drugs like dexmedetomide. We use drugs like dexmedetomide, which is an alpha-2 agonist, which is sedative, sympatholytic, and helps in early bowel movement. Acute colonic pseudo-obstruction, ACPO or Ogilvie syndrome. There is acute massive colonic dilatation in the absence of a mechanical obstruction. This usually happens in older patients, and they usually have some underlying serious medical or surgical condition that is seen in 95% patients. They usually have multiple comorbidities, a hip or a pelvic surgery, some infection, cardiovascular disease. The mortality is 25 to 31%. The age is usually more than 60, and the male is more than the female. Abdominal distension occurs over 3 to 7 days. Sometimes it can happen over 24 hours as well. Pain is seen in 80%, which is usually mild and constant. And the abdomen would have a tympanitic note. If there is marked tenderness, it means the patient's gone into ischemia or peritonitis. The X-ray shows air throughout the colon, unlike in a mechanical obstruction. And there is cecal distension. Haustral folds are still visible. And if you give a water-soluble contrast enema, it can rule out a mechanical obstruction. The differential diagnosis would be a mechanical obstruction, toxic megacolon from any other cause. Cecal diameter of more than 9 to 12 centimeters gives you a high risk of perforation. The treatment is bowel rest. A rectal tube can be used for decompression because an NG will not work to decompress the air in the colon. Fluid resuscitation has to be given. We do not use osmotic or stimulant laxatives because it causes increased gas in the colon, which is already distended with gas. 90% recover in a few days. If there is impending perforation, we go in for surgery immediately, or even if there is no response in 72 hours. We can give IV neostigmine, which is a cholinesterase inhibitor, and it increases acetylcholine in the myenteric plexus, and it increases colonic contraction. We give 1 to 2 milligrams IV over 2 to 5 minutes. It works in 90% of the cases. However, patient can go into bradycardia, in which case we might have to give them atropine. Chronic intestinal pseudo obstruction, or SIPO. This is recurrent intestinal obstruction, symptoms of intestinal obstruction in the absence of anatomical lesions causing an obstruction. Small bowel loops are also dilated, unlike in enteric dysmotility, which is a much milder problem. 50% have an underlying neurological or connective tissue disease or a malignancy. If there is no explanation why the patient is going to recurrent pseudo-obstruction, we call it idiopathic. So it's CIIPO, chronic idiopathic intestinal pseudo-obstruction. Now, SIPO could be primary or secondary, and primary is much more common. Secondary is due to autoimmune diseases like progressive systemic sclerosis, celiac disease, drugs, neuromuscular disorders, endocrine disorders, paraneoplastic syndrome, radiation. The familial forms are autosomal dominant, autosomal recessive, and this is rare. Enteric neuropathies are primary or secondary. Secondary could be because of infections like herpes, or paraneoplastic or neurological disorders like secondary to diabetes, amyloidosis, hypothyroidism, and drugs. Enteric myopathies, what happens is there's fibrosis and vacuolization in the small intestine, circular and longitudinal muscle. 25% have a decrease in alpha-actin in one study. Mitochondrial disorders, this is actually in 20% of patients with SIPO. In progressive systemic sclerosis, there is increased deposition of collagen, thickening and fibrosis of the skin and connective tissue and internal organs as well, and 100% of them would have GI involvement. Dysphagia, SIBO, and delayed transit would be seen. The progression is not altered by giving any immunosuppression. In 40% of them, the contrast CT would show a dilated duodenum and jejunum, fixed, tightly packed valvuloconniventus, which gives the accordion appearance or the hidebound appearance. Dermatomyositis gives rise to dysphagia because of weakness of esophageal muscles. In SLE, you see GI symptoms in 50% of patients. Most common symptom is pain. Now, the pain could be because of mesenteric vasculitis, which could be acute or chronic, and there could be protein-losing enteropathy. SIPO would be present in 2% patients, and of the patients with pseudo-obstruction, 50% also have dilated urinary tracts. In diabetes, the patient could present with gastroparesis, diarrhea or constipation, and fecal incontinence. In Parkinson's, the patient would have oropharyngeal dysphagia, bloating, constipation, gastroparesis. Now, there is a theory that says Parkinson's disease may originate in the gut because of inflammation. Spinal cord injury. The patient has a spinal shock, and there's a complete loss of sensory, motor, and reflex function. In a high spinal cord lesion above T1, there is small bowel dysmotility and phase 3 contractions are seen. In low spinal cord injuries below T10, there are multiple disturbances in the colonic motor activity. Long-term, the spinal cord injury patients would have postprandial discomfort in 40%. Chagas disease is due to destruction of the mesenteric and the mesenteric plexus throughout the GIT. There could be a megaesophagus, in which case the patient would have dysphagia, megaduodenum, megajejunum, and a megacolon. But some people are fortunately asymptomatic. Thyroid disease, there would be dysphagia, dyspepsia, postprandial fullness, bloating, and the most common symptom is constipation. This is because of colonic dysmotility. This can also result in a SIPO, in fecal impaction, and even a megacolon. And patients who have myxedema coma have a paralytic ileus. Jejunal diverticulosis. This presents as a SIBO, it can present as steatorrhea and weight loss. There could be diverticulitis, in which case the patient has pain, bleeding, and even a risk of perforation. And they can present as SIPO and small intestinal dysmotility. MNGIE, which is mitochondrial DNA neurogastrointestinal encephalopathy. This is nothing but familial visceral myopathy type 2. It is autosomal recessive. There is degeneration, fibrosis of the GI and the urinary smooth muscle, and the patient would have dilatation of both the gut and the urinary system. That gives you a clue that this is a genetic problem. GI amyloidosis. There is extracellular deposits of abnormal protein fibrils with beta sheet fibrillar structure. You can stain the small intestine with Congo red and view it in polarized light. Primary amyloidosis is more common than secondary, and this has more GI involvement as well. Secondary amyloidosis, secondary to rheumatoid arthritis, Crohn's disease, ankylosing spondylitis, PSS, and psoriasis. The patient could present with diarrhea, constipation for years, GI bleed, protein loss, perforation, ischemia and necrosis could happen if the bowel vessels are involved, blood vessels are involved in GI infiltration. The treatment of SIPO. Treat the underlying cause, correct the electrolytes, give oral or NJ feeds as 25 calories per kg per day in small, frequent feeds. We can give enteral nutrition because the mucosa is essentially normal. Liquids are preferred. Formula feeds like Peptamen are preferred. Neostigmine, if not contraindicated. And if it is contraindicated, you give mu receptor antagonists. We can do an NG decompression if there is nausea and vomiting. We can give 5-HT4 receptor agonists like prucalopride and cisapride. Cisapride is found to be useful in adults but not in children. Oral pyridostigmine can be used. It's supposed to be useful in both adults and children. Octreotide helps in SIPO due to PSS. So you give it 2 hours after the last meal, that is after dinner. You treat any SIBO. Some patients need cyclical antibiotics for 10 days every month. We can give rifaximin, doxycycline, metronidazole, or even ciprofloxacin. We treat any underlying constipation by giving PEG, that is Laxopeg, plus a stimulant laxative like bisacodyl. We, however, do not use bulk laxatives because it increases the symptoms. Surgery is in those with localized disease, example, megaduodenum. And if all else fails, we try a small intestinal transplant.